Assalamu alaikum. My name is Zaitoon Zafar, and I am a final year medical student at Shalamar Medical and Dental College. This presentation is going to be about operation room based learning, and we are going to be exploring the need for structured learning along with its importance in history, and we are going to be discussing various models of OR based learning along with their merits and drawbacks. So, what is the importance of structured learning in an OR? Why can't surgical training be opportunistic or spontaneous? Well, first of all, surgery is a field that requires infallibility. Even small mistakes during a surgery can prove to be irreversible and result in losses, great losses to our patients and to us. And from a student's point of view, a lot of educational objectives are lost in the opportunistic approach. And what structured learning does is that it sets a standard, a minimum standard upon which fair assessments can be based. So, the history of structured learning. Structured programs actually began in what was then the German Empire in the late 1880s. And simultaneously, a Dr. William Osler, who was one of the founding professors at Johns Hopkins Hospital, he introduced clinical rounds and clinical clerkships to his students. And there was a William Halsted, the one on the right, who was the first chief of surgery at Johns Hopkins Hospital. He was training in Europe for 2 years and he was inspired by the German way of teaching. And he was also a colleague to Dr. Osler. So, inspired by both of these things, he came up with what came to be known as the Halstedian model of teaching. Now, this Halstedian model, it emphasized on the need for mentorship, it emphasized on the patient-doctor communication, and a training that became gradually more complex, which meant that with each passing advancing year, surgeons became more involved with patients and their surgeries became more complex. And this model, developed in the 20th century, became the mainstay of surgical training well into the 21st century and produced numerous excellent surgeons. So we are going to be discussing 7 different models of OR-based learning, from the oldest to the newest. First, we're going to discuss the apprenticeship model, which is old as surgery itself. It dates back to the 16th century. And what used to happen was that talented teenagers or interested teenagers who used to take an apprenticeship with practicing surgeons without any prior medical knowledge, and they were trained for 6, 7 years. It was very informal. There was no medical schooling involved, no university, no hospital training, and it was based on the principle of shadowing. So the apprentice would follow their teacher around, and it was a time dependent process with a see one, do one approach. Now, this model, it guarantees mentorship and has lasted the test of time. The students are not neglected, and it also guarantees one-on-one learning. But the main drawback is that it is unstructured, completely unstructured, with no guidelines, and the teaching is only as good as the teacher, and one teacher can only teach very few students at one time. Lyon's model, which was proposed by Patricia Lyon in 2004, it identified 3 key domains in the surgical or learning setting, which were challenges posed by the physical environment. So, a new environment for students, new teaching, new teaching skills, new surgical tools, and second was the challenge of the educational task. And third, the challenge of managing and negotiating a role as a student, as a subordinate to the surgeon performing the surgery. And this model concluded that the relationship that a student and a surgeon has consequences on their learning experience. The merit of this model is that a student's mental capacity and emotional range, their emotional well-being is taken into consideration, and it also encourages teamwork in the OR. Students are not neglected and self-learning is encouraged. But again, it is an unstructured model. It highlights what is important, but not what is not important, and it does not give a set rules to follow. It is more suited for undergraduates than it is for postgraduates. And it also leans on the ability of students to self-regulate and self-motivate. Number 3 is the briefing, intraoperative teaching debriefing model, and it was proposed in 2009 by Roberts et al. It emphasizes on a more deliberate approach, and it has a 3-step process, including briefing, and these are all taken charge of by the surgeon. And briefing includes short 2-3 minutes interaction prior to the operative procedure. So the surgeon tells the students what they're going to do, why they're going to do it, and the possible complications of the procedure. And then during the procedure, the surgeon walks the students through the procedure. And once the procedure is over, there's a debriefing session during which both the student and the teacher interact with each other and discuss what happened, what didn't happen, and whether there were any complications. The merits of this model is that it is structured, it encourages teamwork, students are not neglected, and it has a compounded learning effect, which is that what students were told in the briefing, they also experience during the intraoperative teaching time, and then again in the debriefing time. But the problem is that the knowledge that the surgeon has, or the knowledge that had to begin during the surgery, may be above the student's level. So it may be a model that is more suited for postgraduates. And another problem is that one surgeon could be having the same surgery 5 times a day, and they may have to brief, teach, and then debrief on the same surgery 5 times to the same set of students, which is not a very efficient way to teach. And then again, the efficiency of this model depends on the teacher themselves. In the Swish model, this was designed in 2013, and it analyzes the attendings and residents' behavior during the operation, and it assigns them into 4 categories, which are show and tell. So whether the surgeon needs to be showed and told what to do, whether the surgeon needs smart help, or whether the surgeon needs dumb help, or whether the surgeon needs no help at all. And after analyzing them based on these 4 categories, it designates them a level of autonomy for any given procedure. The merits are that it helps the resident gain autonomy. So there's a goal at the end of the model, and the resident can assess their own progress. They're not neglected, and it also provides an incentive to teach adequately. Demerits, again, it is a very unstructured model. It only sets a goal for the students. It doesn't tell them how to set a goal, and it's not suitable for undergraduates because we're just learning the basics. The analysis and the grading can also be observer biased, and only a limited number of students can be observed at the same time. So the OMP model, 1-minute preceptor model, it was proposed for gross anatomy teaching in 2011 by Lapke Chan and Jeffrey Weissman. And what they did was they put 5 microskills and assigned them to 1 minute. So within a minute, you have to get a commitment from your student. You have to probe them for supporting evidence. You have to reinforce what was done right. You have to correct errors and fill in omissions, and then teach them a general rule at the end of the day. The problems are varied, but there are also a lot of good things about this model. One, that it is structured, it is time efficient, and only takes a minute. Students are neglected. The whole process is based around the student, and then it provides this incentive to teach adequately as well. Again, the problem is that 1 minute is not really enough for surgical teaching, and it's not suitable at an undergraduate level. The analysis of all the 5 microskills could be observer biased, and only a few students can learn within 1 minute, so it's limited. Cohens Model. This was proposed by Cohens in 2005, and it builds on the concept of medical education. It identified 3 dimensions of context, one being the physical dimension, which is the OR itself, the machinery, the tools, a semantic dimension, which is reflects on how well the context contributes. So the student has to be aware of how much this experience is going to help them in the exam. And then the commitment dimension, representing the amount of commitment. So again, the student has to recognize how much weighs on them and how much responsibility is being given to them during this time. The merits are that there's a compound learning effect, which is that the students, what they learn in the physical dimension, it's reinforced by the semantic dimension and the commitment dimension. And then students' well-being and their mental capacity is taken into consideration. It follows a holistic approach. It looks at the student as a whole, the environment, the teacher, and then it also provides an incentive to teach and learn adequately. But again, it is a very opportunistic model. It's not structured, and the analysis could be observer biased. And it depends, again, on the student's motivation and self-regulation. It takes for granted that the student will be responsible. And the 4CID model, which was proposed on medical education in 2014. And what it does is that it has this basic assumption that anything can be learned in 4 steps, which are divided into learning tasks, supportive information, procedural information, part task practice. So this means that first the students would learn about the procedure, and then they would learn about the information that supports the procedure, and then the information during the procedure, and then they would actually perform the procedure. The merits are as follows. It's a very structured program. Again, students' mental capacity and motivation is given importance. It is a holistic approach and it has compounded learning. It isn't suitable for surgical education because even in simulated environments, it's not very possible to keep practicing surgery again and again. And in real time, surgery has the added risk and danger of someone dying. And it's unstructured, it's timely, and it depends again on the student's self-motivation and self-regulation. So we have been conducting a study, and in our primary survey of 18 experts, 100% of the participants favored structured learning, and the briefing, intraoperative procedure, and debriefing model, followed by the Cohens model, were the models that were given utmost relevance. This report is yet to be published, but these were the results. Thank you so much for your time.